I'd like to welcome all of you. Today's topic is COVID-19 and SinoNasal MucorMycosis. This webinar is being conducted under the aegis of United Medical Mission, which is a network of NGOs based in Bangalore, India. And they're endeavoring to improve the healthcare status in India by organizing preventive clinics and camps, raising public awareness, and also getting involved in public-private partnerships. They plan to open up medical centers, counseling and rehabilitation centers, medical training platform, and of course, there's global affiliation. There are people from across the world which are associated with United Medical Mission. And if anyone amongst the audience today wants to contribute or wants to be part of this endeavor, they could get in touch with us over the email. The email is unitedmedicalmission@gmail.com. And of course, it is also there in the flyer. You can get in touch with us regarding the activities of United Medical Mission. To talk about this topic, I'm sure everybody today is talking about the black fungus SinoNasal MucorMycosis. There's been a sudden surge in post-COVID patients. And to deal with this topic, we are very honored and proud to have a very eminent speaker, Dr. Rupa Vedantam, who is a professor of ENT at CMC Vellore. She's been head of the Department of ENT, and she's head of the unit of Department of ENT at CMC Vellore. Dr. Rupa is one of the pioneers of fungal sinusitis in India, and she has presented a lot of papers in India as well as abroad. She has more than 100 publications in peer-reviewed journals, and she did her master's in ENT in 1987. She also has a diploma in otolaryngology in 1985. She has a very illustrious career spanning 34 years. She's been awarded with some prestigious awards. She was the best outgoing student of Madras University in 1987. Also, the best outgoing student in the state of Tamil Nadu in the year 1987. And she has, as I mentioned, she has received a lot of awards. She's been in the teaching faculty for the last 34 years. She has trained and mentored and taught a lot of students, both at the undergraduate and postgraduate levels. I'm sure many of the postgraduate level students she has mentored and taught are practicing ENT all over India, and I'm sure outside India as well. Dr. Rupa has also published, she has written chapters in 6 books, and she has written a book on emergencies in ENT. I could go on, but for the sake of saving time, I would like to hand over the mic to Dr. Rupa. And Dr. Rupa, please go ahead with your talk.
Good afternoon. I thank you, Dr. Imtiaz, for being so kind. That was a really lovely introduction. Really, I haven't done all that much, but the little that I have been able to do, I must thank my colleagues and there are so many other individuals involved in the Department of ENT and other departments who've helped us through the years. Now, I have had an abiding interest in the matter of fungal sinusitis, and this has been for over 20 years. And this has largely been because of our practice here at CMC. This practice involves us seeing a number of cases of fungal sinusitis. My initial interest was in non-invasive fungal sinusitis, but more recently, because of the increased prevalence, the upsurge of invasive fungal sinusitis, I tend to sort of have more of a research interest in this area. Now, before I proceed, I'd like to thank the organizers especially Dr. South of the United Medical Mission for so graciously inviting me to make this presentation on a topic I think that is really very timely. So what is in the news today? And as I was talking to Dr. Imtiaz just now, and he was telling me even his mother was very interested in this black fungus. If you look at the news nowadays, what you see, BBC News on the 10th of May, one of the headlines was that the black fungus maiming COVID patients in India. And in Times of India, you have another headline saying COVID patients losing jaws to mucormycosis. And as you can see, these are very sensational headlines, which immediately the lay public picks up and wants to know what to do about this infection. Mucormycosis, what is it? Well, it is an uncommon, and I would say right now, not so uncommon, rapidly progressive, often fatal opportunistic infection of the paranasal sinuses, which then goes on to the orbit and intracranial compartment. Now, mucormycosis comes under this classification by Dishazo of all types of fungal sinusitis into non-invasive and invasive. Mucormycosis belongs to the acute category. Now, we once analyzed about 266 cases of fungal sinusitis, and you can see by this distribution that the majority, the blue and the red, belong to the non-invasive category. It is just this green area, this small segment, which constitutes acute invasive fungal sinusitis, and mucormycosis is one type of acute invasive fungal sinusitis. How is it defined? It's really defined by the duration of the symptoms. The duration of symptoms usually is counted in hours or days, but the standard is less than 4 weeks. So if a person has symptoms lasting less than 4 weeks, we would consider this as being acute invasive fungal sinusitis. As I told you, these are the two main categories: mucormycosis caused by the organisms Rhizopus and Mucor, and acute invasive aspergillosis, which is caused by the organism Aspergillus. Now, one study done in the West has shown that fungal infections in COVID patients form 4.6% of all patients who had severe COVID-19 disease. Of course, during the COVID era, as we have seen, and we've just been talking about it, that mucormycosis is far more prevalent during this COVID period than at any time before that we have seen. So let's look at these fungi. How do they look? What are they called? What sort of diseases do they cause? Basically, there are two classes of fungi. The first class is called zygomycetes, and the second one is called ascomycetes. Under zygomycetes, you have Mucor and Rhizopus species. Mucor forms these broad filamentous fungi, fungal filaments. These are also called hyaline moles. Interestingly, these are colorless, but we get the term black fungus. I'm not too sure why, but definitely it's not because of the appearance of these fungal hyphae. They are quite colorless. And the organ of reproduction, the sporangiophore, is globose and contains multiple spores. On the other hand, you have Aspergillus, which produces these thin, not broad, thin septate fungal hyphae with acute branching. And if you look at their sporangiophores, they're more radiate, more like a medusa head. Now, although they look so different, both of these fungi are very important in the causation of acute invasive fungal sinusitis. Histologically, what do we see? Well, there is an acute inflammatory reaction. Again, the pathologist will try to identify these fungal forms within tissue. This tissue that is invaded includes the mucosa, submucosa, blood vessels, and bone. Typically in mucormycosis, there is invasion of the blood vessel. Here's a thick walled vessel, and right in the center, you see a lot of fungal forms. If you want to demonstrate these fungal forms better, you can use a fungal stain like the GMS stain, the Gomori methenamine silver stain, and here you can clearly see all the fungal forms. So as opposed to Aspergillus infection, Mucor typically causes angioinvasion, and that is really what the pathologist looks for. Now, what are the predisposing factors in this disease? You want to know, the lay public wants to know, we as doctors want to know which kind of patients are more likely to get the disease. Now, in the pre-COVID period, it was very clear-cut: poorly controlled diabetics, immunosuppressed patients, patients with a lot of rheumatological disorders on immunosuppressants or steroids, patients with hematological disorders, leukemias, post-bone marrow transplant patients on steroids and immunosuppressants. So these were the classical cases. But now we find during the COVID period, we're finding patients who were never diabetic, having been given steroid during the period of COVID, realized that they were actually pre-diabetic and now have become frankly diabetic and therefore more prone to invasive fungal infections. The indiscriminate use of potent antibiotics. COVID itself causes pneumonia, but then you have physicians treating this as a very serious bacterial pneumonia and giving very potent antibiotics. And where you have strong antibiotics given, you find an upsurge of invasive fungal infections. So definitely that is another reason why we are seeing a lot more of this. There's been an increased incidence of invasive fungal infection even in patients who've been given monoclonal antibodies. Now, monoclonal antibodies like tocilizumab, which is an IL-6 inhibitor, have recently been included in the management of severe COVID disease. And this also, although it has been brought in as an alternative to steroid therapy, can predispose to the development of fungal infections, as has been shown in some studies. What is the immunology of this disease? And this is really what people want to know. How does this infection occur? And to understand the immunology of infections in general and fungal infections in general in particular, let us just look at these two diagrams. Let's start with this first diagram. Now, the three most important cells which are involved in the process of innate immunity, which is the first step in immunity, in the immune response in all of us, are the neutrophils, the macrophages, and the dendritic cells. So all three of these cells actually can ingest these fungal organisms and then produce on their surface and sometimes within themselves pattern recognition receptors. These are MHCs, major histocompatibility complex, or HLA complexes, which can be seen on the surface of these particular cells. Now, neutrophils, they are important because they actually are involved in phagocytosis, and their migration to the site where phagocytosis has to occur and their ability to phagocytize these fungal organisms is impaired in the presence of hyperglycemia. So you can see how diabetes can impair neutrophil function and therefore reduce the immune response. Now, if you look at the dendritic cell, again, that gets activated. It ingests the fungus form and migrates to the lymph nodes. When it goes to the lymph nodes, that is where the naive CD4 and CD8 cells lie. They then get stimulated to actually convert into Th1 and Th17 cells, or T helper cells 1 and T helper cells 17, which in turn release a lot of cytokines, and these are all involved in the immune response. Now have a look at the second diagram. You have fungal spores here that can actually enter through the respiratory mucosa and come within. Fungal spores are ubiquitous. They're seen everywhere. They're not localized to a particular point. They don't depend on what kind of fluid we are using to wash our face. It is there everywhere. It's in the air. So they can, in most of us, traverse the mucosa, but then nothing happens to them if they remain as spores. But in the presence of hyperglycemia, they can actually germinate, or in patients who have poor immunity. And when they germinate, a lot of things happen. So you have these dendritic cells which then actually ingest these fungal forms And then they present these fungal forms, as I told you earlier, to the naive CD4 and CD8 cells. And when they do so, they actually release interleukin 23 and TNF alpha. Interleukin 23 then stimulates the Th17, that is the differentiated CD4 cells, to secrete IL-17. That then stimulates neutrophils to produce antifungal defenses. So this is really how neutrophils act against fungal infections. The other cytokine that's produced is TNF alpha, and that induces the conversion to Th1 cells to produce IFN interferon gamma, and that actually destroys these fungal forms. So here again, the immune response, innate immune response, comes up to destroy these fungal antigens. Now, these fungal hyphal forms have an affinity for blood vessels. I told you about that earlier when I talked to you about the pathology. So they have an affinity for endothelium, and they tend to go through endothelium and get into the intravascular space. And that is where they bind with platelets. And you know that these aggregates cause thrombosis. And when they cause thrombosis, they cause infarction and necrosis in the distal segment. So this really is the prime pathology in mucormycosis, that the vessels are invaded, the blood supply is cut off, there is necrosis, infarction, and then subsequent necrosis of the surrounding of the tissue distal to that. And that is really what causes all the destruction in mucormycosis. Now, COVID disease causes a cytokine storm. We know that a whole lot of different kinds of immune mediators are released. And when you give steroid therapy, the early response, all that I told you about earlier, all of that is suppressed. So you can well imagine that this then becomes a free playing field for the fungal organisms to actually invade tissue and blood vessels and cause all the problems that we will talk about soon. Let's look at the pathway of spread. So the disease starts initially as SinoNasal disease, disease affecting the nasal cavity and the sinuses. And then it spreads to the orbit. As you can see, it's very thin bone. The lamina papyrus is here and the floor of the orbit. And the disease easily spreads to the orbit. And very often the bone is intact because the disease spreads through vascular channels. And then, of course, the disease can spread intracranially, starting primarily through the cavernous sinus, causing cavernous sinus thrombosis, then the internal carotid artery, then infarction of the brain parenchyma, and involvement of the brain parenchyma. So sequentially, and over a very short period, the disease can spread. So what are the differences we are seeing in the demography in the pre-COVID and COVID era? So really, it's quite similar to what we're seeing in the pre-COVID era, except that we're seeing a lot more male patients. That was the same before, but the difference is more, and that is clearly because COVID, we know, is much more common in the male patients. Likewise, we are seeing far more in diabetics, 76% in the pre-COVID era and 94.3% in the COVID era. And this again reflects the fact that this disease is far more common among the diabetics. What are the clinical features? Now, the clinical features, interestingly, haven't changed with time. They remain pretty much the same as in the pre-COVID period, where headache, facial pain, loss of vision, and orbital signs, proptosis, periorbital swelling are the early symptoms and signs. A very small proportion of them, less than 5%, go on to developing features of intracranial extension. Many patients may not clinically show evidence of intracranial extension, and it's only on imaging that we're able to pick this up. And definitely, this is far more common in the COVID period. Now, this is what most patients look like. You can see swelling, facial swelling, just little periorbital swelling. Some of them develop ptosis, and the facial swelling becomes diffuse, particularly if it's bilateral. Now, this picture in which you see black discoloration of the skin, I suspect this must be the reason why it's called black fungus. But this, let me assure you, is quite rarely seen, not very commonly seen. But yes, this can occur when there is necrosis of the skin. What do we see on rigid nasal endoscopy? Because that should be the next step. And we most often tend to see abnormalities like a thick mucopus within the nasal cavity. We see very unhealthy mucosa. In some patients, you'll see necrosis and a lot of crusting. And not so commonly, you might see a complete black looking turbinate because of necrosis. And in some patients, I would say around 10%, you might actually see absolutely normal looking nasal mucosa. And that happens every once in a while. It is important for you to have a high index of suspicion in these patients, particularly going by all the clinical features that I spoke to you about. Now, on examination, never forget to look into the oral cavity. I always tell residents you may do an endoscopy, you may do a clinical examination, but if you omit to look into the oral cavity, you've really missed out a lot. You've literally put your foot in the mouth. You could miss a palatal ulcer. Now, or you could miss necrotic bone. Sometimes you might pick up an oroantral fistula or a loose tooth. Sometimes, in fact, if you hold the whole jaw with your fingers between your thumb and your index finger, you can move the entire jaw because it is so loose and necrotic, although the mucosa around it might appear intact. So this is important because our management really depends on our assessment of the extent. And this is the reason it's really important for you to do a thorough oral cavity examination too. What are the investigations that we do? The first step would be to do an urgent fungal smear. And here you need to be in touch with your microbiologist so that you get an urgent report too at the same time. If you see a lot of pus, that would be the best specimen to quickly swab and send. If you do not, you would need to do, or you see a lot of necrotic tissue, take that in your forceps and send that for urgent biopsy. But just remember that tissue really needs to be digested and then assessed. And sometimes fungal forms can be destroyed in the process. So you may not get a positive result. And that may be one of the reasons why you do not get a positive result. You should do a biopsy, and obviously it is the most affected area that you'd select for taking the biopsy. But if everything looks normal, studies have shown that it is the middle turbinate which is the best site, which will yield the maximum if you take a biopsy. Frozen section is ideal, but remember, frozen section is not advisable in COVID positive patients because while you can do a frozen section in the pandemic, if your patient is positive, you would not do a frozen section. Blood tests basically to assess the extent of diabetes, the blood sugars, HbA1c, generally in the range of 7 to 10. Look for the renal function, do serum creatinine and electrolytes. See if the patient already has some evidence of immunocompromise, and check the absolute neutrophil count. I think in a few slides earlier, I told you the absolute neutrophil count is often reduced in patients with hematological disorders, and that is something that you need to check. The next step would be to do a contrast-enhanced CT scan of the paranasal sinuses and base of skull. And this then will show us the extent of the disease and evidence of bone erosion. And when you suspect orbital or intracranial extension, it's important to do a gadolinium-enhanced MRI of the paranasal sinuses, base of skull, and brain. What are the radiological findings that you see in these patients? Well, almost 100% in one series that we published earlier, all of them had some evidence of mucosal thickening. In this coronal CT scan, you can see a little mucosal thickening in the left maxillary sinus as well as in the nasal cavity. In other cases, as you see in this axial cut here, there's very little evidence of ethmoid disease, but you see orbital apex involvement. About 20% of these cases show non-enhancing mucosa, and that is something to be borne in mind. Bone erosion is also not very common. In this scan that you can see here in axial cut, you see a lot of disease in the right ethmoids. You also see it in the orbit. You also see it interestingly in the region of cavernous sinus. You have the opposite side cavernous sinus, which is nicely enhancing, and this one is not enhancing, suggesting the presence of cavernous sinus thrombosis. Now, in this axial cut, what you can see is loss of fat plane. This is a very early sign to show evidence of involvement of the pterygopalatine fossa. In this normal side, you can see this hypodense area representing fat in the retroantral plane, and that is completely missing in this side, that is the affected side. Now, what about MRI scans? As I said, they're used when there is suspected orbital involvement. I've given a figure of 50%. That is what we found in this study, but I'm sure it is much higher now in the COVID era. You have here enhancing lesion in the orbital apex, superior orbital fissure, and this also increases the enhancement along the lateral wall of the cavernous sinus. In this coronal MRI scan, we see enhancement of the cavernous sinus as well as the pterygopalatine fossa and the pericavernous area. Now, this interesting scan, which we had in one patient, it's not common. We can see a space-occupying lesion in the right temporal lobe. This lesion is circular. It has a hypo-intense area in the center and hyper-enhancing area in the periphery. And this is a temporal lobe abscess, a rare complication of fungal sinusitis. Don't miss out, the right orbit has been exenterated. Now, the management of mucormycosis involves a multidisciplinary approach, and that's really very important for us to understand. When we want to start a service that involves the management of these patients, the first thing to do is to gather your team around. And that is something that we have done over the years. The prime movers of this are the otolaryngologist and the ID or internal medicine specialist. Along with them, you have the endocrinologists, anesthetists, and so on and so forth, all of these various specialties who are each one of them vital in the holistic management of these patients. So the steps of management include, as I said, clinical workup, sending sugars, electrolytes, all the blood tests, COVID tests, do an endoscopy, send fungal smear and culture, frozen section if possible if COVID negative, scanning, control the sugars, find out the COVID status. Then if you find that your smear is positive, then you can, in this COVID era, start patients on antifungals. In the pre-COVID era, we would insist on histopathological confirmation. That is not always possible. Also, if you get a negative smear or frozen, have a high index of suspicion and go ahead and take up these patients for an urgent debridement using an endoscopic approach primarily, but adding on a maxillectomy or orbital exentration as and when required. All specimens should be well labeled based on the side and site, sent for fungal smear and culture. And when the histopathological processing is done, I am sure your pathologist will ensure that fungal stains are also used to identify the fungus. The precautions to be taken during the COVID pandemic, we know that the highest viral load is in the nose and paranasal sinuses. So it's really important to protect yourself using complete PPE. These are aerosol generating procedures, and some surgeons I've seen in private practice in India, but or definitely in the West, having these PAPRs, powered air purifying respirators, which enables them to do surgery for quite a long time. Otherwise, you have to sweat it out in these PPEs. You can do a betadine wash of the nasal and oral cavity. And the separate OR is required for COVID patients, and the absolute barest minimum number of personnel should be in the OR when these cases are done. Now, over the years, we have formulated an important change in our surgical protocol for the management of these patients, and I thought I'll share this with you because it has helped us in sort of managing the disease. Now, if you look at these various studies that I have listed in this table here, starting from 1991, 2007, 2016, you've had surgeons who've done no less than 2 procedures, sometimes 3 to 8 procedures, and these are their survival rates. Now, these surgeons, particularly in the last study, have insisted that doing these various procedures is really important towards their, sorry, somebody, is really important towards the ultimate improvement in survival. But what we did was to insist on operating on both sides, even if the patient radiologically appeared to have unilateral disease. We now explore both sets of sinuses, and we found from this study that we published last year that this protocol reduced revision surgery from 28.1% to around 4%. Our outcomes were also comparable, 63.6% and now 68.2% in the most recent study. If you look at diabetics alone, it was 73.5%. So overall, without compromising outcomes, by doing a single procedure with a specific protocol in mind, we have found that this is possibly the best way. And I would think in this COVID era, it is all the more important to not take the patient in not more than a single time to completely clear out the disease. This is one such case, and we actually, to quantify it, showed that 6 patients who clinico-radiologically were negative for the disease, like this is one example of these patients. You can see the right side maxillary sinus ethmoid looked clear. Clinically, it was clear. We sampled both groups of sinuses and both were positive. So what happens sometimes is when you leave behind residual disease, maybe it was this turbinate, maybe it was this middle turbinate, and or a part of the septum on this side, then there is need for revision surgery and you end up operating multiple times. So doing a single complete surgery sometimes is a very good choice of protocol. What are the intraoperative appearances? You can see here, many patients have just some edematous mucosa, which looks a little unhealthy. This here is the lamina papracia, the middle turbinate on the left side, some edematous mucosa. You may be able to see some fungal debris interspersed with this edematous mucosa. Sometimes you may be able to see necrotic tissue involving the bone, but by and large, it's not very remarkable. Some polypoid tissue, some edematous tissue, some unhealthy looking mucosa. Rarely you see absolute black material that which possibly could be called black fungus. Now, the clearance should be adequate. And here I show you endoscopic appearance just before surgery and soon after surgery. The entire unhealthy mucosa should be cleared out such that you can see a healthy ethmoid sinus on this side. Likewise, when you remove debride a palatal lesion, completely clear it out such that only healthy bone and mucosa remain, and this mucosa will grow over the bone and leave a very healthy cavity behind. Orbital exentration. Now, there's a lot of doubt in the minds of ENT surgeons as to whether this should be done. I looked at the article by Hargrove and colleagues, which actually was a meta-analysis of 113 articles from 1943 to 2004. And they had conflicting results. At the end, all they could say was there is no standard of care exists to guide physicians regarding the need for orbital exentration. So that leaves us neither here nor there. This interesting article by Songu and colleagues showed that orbital exentration may not be required in the majority. And if you just debride periorbital tissue, as we have done for many cases, that may be sufficient. I picked out this case report because of the good documentation in the single case report by Hirabayashi and colleagues, which described a 68-year-old gentleman with rhinoarbustocerebral mucormycosis who had worsening vision after endoscopic sinus surgery and commencing L-amphotericin B, liposomal amphotericin B. The authors injected intraconal amphotericin B. This, they called it a globe sparing, minimally invasive technique. Their outcome was actually quite good. This patient had a frozen eye, and you can see with time that his vision was reduced, was restored, and so also the extraocular movement. So this is definitely something that needs to be explored in a bigger way, possibly in the Indian context. And now I will talk about antifungal therapy. Antifungal therapy, so while surgery forms the backbone, the first step, antifungal therapy, has to follow soon after. It is not to be delayed. Amphotericin B is the drug of choice for mucormycosis, and it is indicated in all patients with rhizopus or mucor infection. Now, amphotericin B is available, I would say, in 3 avatars, as they say, but we have in India most patients, unfortunately, using plain amphotericin B deoxycholate, or conventional amphotericin B. This is perhaps the cheapest form of amphotericin B, as you can see here, but the problem with it is it's very toxic. In fact, the most recent European guidelines actually tell us to avoid using conventional amphotericin B, but then we are hard pressed to use anything else because of the sheer costs of treatment. Liposomal amphotericin B is given at a much higher dose, 3 to 5 milligram per kilogram per day. In the West, they give usually 5 to 10 milligrams per kilogram per day. In fact, they say for intracranial extension, one should give 10 milligram per kilogram per day. We have an alternative, which is a little less expensive, but almost equally effective, which is lipid-soluble or lipid emulsion amphotericin B, which is given at a slightly higher dose. There, as I told you earlier, there are multiple complications of amphotericin B therapy. During the process, you have fever, chills. Many of them go into renal dysfunction, necessitating discontinuation of therapy. This then makes the therapy inadequate, restarting. You have to start all over from scratch. So it is not a good way to go. Many of these patients develop central or peripheral line thrombosis. Of course, all these complications are much less when you use a liposomal amphotericin B. Hypokalemia and hypomagnesemia are also described complications. The azoles. The azoles are other important antifungal therapy and of late have acquired greater prominence. Of these, posaconazole has pride of place. A few years back, we started with getting syrup posaconazole, which is very expensive. Then the injection posaconazole came into being, and now we are lucky. Well, before or just about before the COVID pandemic started, we have these slow release tablets, which are also less expensive, and 300 milligrams a day. You can send the patient home on oral therapy, have less chance of super infection when they go home, and tolerability, less chance of other amphotericin B related complications. So it is a good step down therapy in patients who have received an adequate dose of liposomal amphotericin B first. Isoconazole is also now well regarded in the West, not so widely used in India. And I've mentioned voriconazole here because voriconazole is the drug of choice for invasive aspergillosis. Not as common as mucormycosis in this era, but still some series do describe cases, and we also have seen a few. And this really, in Herbrecht's study, is shown to be far superior than amphotericin B in the management of aspergillosis. What about posaconazole? Now, we did a study in CMC with the ID department, and this is similar to studies done in the West. We had 12 patients. 8 patients showed a complete, 8 patients, it's about 67% showed a complete resolution of disease. The drug was well tolerated. The only side effect was diarrhea. So posaconazole, all in all, is a good drug for us to have as an antifungal. Now, antifungal assessment in vitro is by antifungal susceptibility testing. And this, in this study by Thompson, published in 2009, has some interesting findings. So while aspergillus species are mostly all susceptible to the azoles, you find that Aspergillus terreus especially is resistant to amphotericin B. So knowing which species is very important, because then you know which antifungal drug really is most effective. As far as zygomycetes go, this study actually shows that it's a variable response, and that is a worrying thing. That means that all patients may not respond to amphotericin B, and that really is the only main drug that we have as the first line therapy. But then we need to remember also that in vitro responses don't always mirror in vivo responses, and really what happens in the patient may be a little different. So actually we did this antifungal susceptibility test. We actually just got accepted this study. We looked at patients who had undergone treatment for invasive fungal sinusitis, and we looked at the antifungal susceptibility pattern. And this is best understood by looking at the MICs, that is the minimum inhibitory concentration of the drug that was sufficient for this particular drug. For amphotericin B, you had very low GM-MIC. GM stands for geometric mean. So we had very low mean MICs for amphotericin B for mucor and rhizopus. So that sounded very promising. But when we looked at the association with the in vivo response to see, well, if they did well and they had low GM-MICs, did they do well? We found no correlation. We've had a P of 1. Now, why did this happen? This is simply because of the complications from amphotericin B therapy. We know it is very toxic, and this then can confound outcomes. So perhaps a good study would be to look for this in patients who've had liposomal amphotericin B. Now, rehabilitation is also a multidisciplinary process. I won't dwell much on this here. Suffice to say that even if the patient has had orbital exentration, patient can have an artificial eye, and even if part of the jaw is removed, a temporary prosthesis and later a permanent prosthesis can be inserted so that normal feeding can deglutition and as well as speaking is there. And even if there is skin loss, you can either put a skin flap or have a good prosthesis. Now let's look at the trends in the incidence of acute invasive fungal sinusitis. Now during this period, I actually do not have much data from our institution, but I have a little bit, and this is just 73 patients that we saw. Last year, the blue color, you can see that the peak of the cases was in September, and this corresponds with the first wave of the pandemic. And this red color is the present peak of these waves, and you can see that the peak is still not reached. Our case numbers are really increasing. Over the last 2-3 days, we've had close to 10 or so patients, and the numbers of patients along with the second wave will clearly show that it's at the peak of these waves that we seem to be getting the maximum number of patients. But I did look at a few studies, and these studies have all been published between November and April of last year and April of this year, and they're all interestingly Indian studies. As we discussed earlier, it's India that really is seeing a lot of this, and it's important for us as ENT surgeons to know what is happening in our country. So this first study by Murthy and colleagues is from Bangalore. It's a group of private practitioners in different major hospitals in Bangalore. Obviously, some hospitals are not represented. They had a really big series of 18 cases. The mean age was around 54.6, quite like the pre-COVID era. Everything else is similar to the pre-COVID era. They had a mixed group of organisms, mucor and aspergillus, far more mucormycosis. Now, the difference is you have more patients who had prior COVID and only 4 patients who had COVID at the time of surgery. I would presume these patients were asymptomatic or very mildly symptomatic for COVID. That unfortunately is not described in that article. These patients underwent various procedures, and about 40% of them had orbital exentration. All of them received amphotericin B, liposomal amphotericin B and posaconazole. Sorry, I've gone to the wrong study. All of them received liposomal amphotericin B, and the outcome actually was quite good. You had only 33.3% of them mortality. So one was lost to follow-up. So that was not too bad. Then we have 2 other series. Both of these are actually primarily from ophthalmological services, and they are a series of 6 patients from a group in Hyderabad and 10 patients from a group in Puducherry. You can see that more or less they are similar, But in these two groups, you find that the mortality is much, much more in the second group than the first group. Now, why could that be so? If you look at the COVID status, while only 5 patients, one patient had COVID at the time of admission and surgery, all 10 patients in this group had COVID at the time of surgery. And as I presume, they might have had either moderate to severe COVID, and which is why it may explain the higher mortality. Now, being ophthalmology services, you can see some of them had even intraorbital irrigation with amphotericin B. One group, though, was treated with posaconazole and the other did not receive it. So, what are the challenges in the management of COVID-19 and mucormycosis in India now? Well, these patients still seem to be presenting late, a lot of them with intracranial extension. There are high costs both for evaluation and therapy. There are very few reliable laboratory services available even in big cities, both for mycology and histopathology. And many of my colleagues will lament that they cannot get a nice positive result. There's a sharp upsurge in the incidence in the first and second waves, as I showed you in the graph. And so most of the resources which are required for COVID care have to be diverted towards the management of these patients. The antifungals are not freely available. I'm told there's a scarcity in many big cities in India. The cost is high and toxicity is still high. There is indiscriminate use of steroid. Patients sitting at home with mild or asymptomatic COVID are popping steroid tablets. And then those who are diabetic have not ensured that their diabetes is under control. Very strong, potent antibiotics are being prescribed. And even the use of steroid alternatives like IL-6 inhibitors are not being used with caution. So what can we do as ENT surgeons and as physicians in general in the management of these patients? Be prepared for the third wave. This is what I will say. We absolutely were not prepared for the second wave in more ways than one, and definitely in the management of these unfortunate patients with mucormycosis, be prepared. Have strong guidelines on the use of steroids in COVID-19 patients. I know that there are GOI guidelines, but these need to be widely disseminated. And when you have guidelines, there should be some sort of regulation when they are broken. Highlight the complications of uncontrolled diabetes and misuse of steroid to the lay public. I mean, if they know about black fungus, equally they should know about the complications of uncontrolled diabetes and steroid therapy. Provide better labs. The government should do this for mycology and histopathology and enhance existing facilities in government hospitals. That really has to be done on a war footing so that these patients are diagnosed early and treated more effectively. Have clear-cut guidelines on antifungal therapy. As you can see from all that I have shown, there is quite a bit of diversity in antifungal therapy. That has to be ensured. Their availability. Can you imagine that if you are told there are no further antifungals available, you will have to turn away all your patients? That is a horrible situation. In fact, I feel a task force should be constituted at the earliest to address this. And perform well-designed control studies. This is a good time to do that on antifungal combinations. Studies in the past from the West have shown that combination therapy is not as effective as monotherapy. Step-down therapy or salvage therapy may be more effective, but that still needs to be proven well in India. And evaluate the role. I feel that there may be a role for screening CT of the paranasal sinuses, as well as prophylactic antifungals in moderate to severe COVID patients who will require either steroid therapy with or without monoclonal antibodies. I think they may, like just as you do screening CT thorax, there may be a role. If you find a patient with extensive disease, COVID disease, then it may be better to go ahead, screen the CT of the sinuses, and if there is disease, start them on prophylactic antifungals. This is just a thought. Of course, this is a modality that has to be carefully worked out. So this management of these fungal sinusitis patients, as you can see in these various pictures, A whole lot of doctors have been involved at our institution in the management of these patients, but I would like to highlight 3 of my colleagues who have really borne the brunt during this first and second wave: Dr. Reggie Kurian, Dr. Lali Verghese, and Dr. Lisa Cherian, who have been working tirelessly through this pandemic in surgically and medically handling these patients. But then there have been a whole lot of other doctors who have gone through our unit and have been involved actively in the management. Many of them have left our institution. We have had a number of CME programs on the management of fungal sinusitis, and this has helped us actually develop protocols in management. And in this photograph, which is very something that I'd like to highlight, we have representation from other specialties, but also people, multidisciplinary involvement by the ophthalmologists, ID specialists, hematologists, all of whom have helped us manage these patients effectively. And with this, I'd like to end my talk. And if there are any questions, I'm happy to take them. Thank you.
Thank you very much, Dr. Rupa, for a very extensive and informative talk about a topic which is affecting everybody at the moment. People are, as you rightly mentioned, it's our colleagues, general practitioners, internists, ENT, ophthalmologists, maxillofacial, even the laymen there, discussing about the surge in this black fungus or rhinocerebral mucormycosis. So there are a couple of questions which have been put by the audience. But before I go to those questions, I have a question, because this question keeps coming up quite often. So there is very limited data about the combination therapy. So in your experience, what is the rationale? What combination we should use? Is it effective? Does it have an advantage? Could you throw some light on it?
Yes. So combination therapy could be simultaneous or sequential. Basically, that is the classification of combination therapy, and that's a good way to go. When we in CMC, most often we have tended to give it sequentially. We start primarily as first line therapy, start with amphotericin B, and then either because the patient cannot tolerate it, or because they have developed complications of therapy, or they're just not responding to therapy, then we go on to salvage therapy, and then usually it is the azoles, posaconazole, that we have used. There was one paper from PGI Chandigarh which talked about effective combination therapy at the skull base for these extensive disease, and they found actually it very effective to sort of treat patients with both azoles and amphotericin B. There's one study from Pakistan also that has showed it to be quite effective. But these were actually, if you look at both of these studies, they have combined both acute invasive and chronic invasive and chronic granulomatous invasive fungal sinusitis. So if you look at just acute invasive fungal sinusitis, I would say that combination therapy is probably the way to go given the high toxicity of amphotericin B. By and large, posaconazole has not been given as the sole therapy for fungal sinusitis. At least there have been no studies that have shown it to be effective as the sole therapy. So we will have to go with some kind of combination therapy. But then each patient has to be looked at individually. I hope that answers your question.
It does, but there is another question that comes up. There are people who are advocating concurrent use of liposomal amphotericin B and posaconazole.
To my mind, yes.
Protocol.
Now, to my mind, this is almost impossible in India because the drugs are so very expensive. But I suppose one could use it, but it is not the protocol that we follow here. By and large, we do not follow that here. We start off with, of late, we have started a protocol giving first amphotericin B and then giving posaconazole as step-down therapy. But giving both is an expensive proposition, perhaps in situations where it is possible. Well, that has to be seen. Really, as you can see in many of the studies, combination therapy hasn't been widely used.
Exactly, that's what I meant. There is no, there's not enough data available which suggests the advantage of a combination therapy. And as you rightly mentioned, it should not be the routine. Maybe in a rare case where the patient doesn't respond, you could think of other options. The
Correct.
other question, which is very commonly, which comes up, is the duration of antifungals in a case of rhinocerebral mucormycosis.
All right. So when you look at duration, really, it's a very interesting disease. Unlike, say, antibiotic therapy, one doesn't say 10 days, 15 days, 2 weeks. There are a number of factors that affect the duration of therapy. One of the important things is, number one, is the therapy have to be interrupted now and then? And if it has to be interrupted, then of course you have to look at, how long the therapy has to be continued. So you have to constantly evaluate your patients and look at their response and decide on the duration of therapy. But by and large, people who have received at least 3 grams of, say, amphotericin B, and who have, maybe if they've started on posaconazole, taken at least maybe about 3 months of posaconazole therapy, would have by the end of it received adequate therapy. Because the way to assess this is both radiologically and clinically. Radiologically by doing a MRI scan, and clinically by taking a biopsy, doing an endoscopy and taking a biopsy from the cavity that is left behind after debridement surgery.
Thank you very much. That was the practice in our center as well. When we had a patient of mucormycosis who would undergo surgical debridement, we would take biopsies, and depending on the biopsy results, we would continue or discontinue the antifungal treatment. So
Correct.
there is other questions. So one of the questions which is a lot of people are talking about is povidone or betadine irrigation after surgical debridement. So does it have any role? Do you have any personal experience about this?
Now, you said after surgery, is it? Is that what you're saying?
Yes.
After surgery. Well, that's interesting that you brought that up. Now, in the pre-COVID era, these patients, as per our protocol, would be brought to the outpatient on a weekly basis, undergone suction clearance, and thoroughly debridement. The cavities are thoroughly debrided, and they are instructed to use saline irrigations. But that's not the case now. In the COVID period, these patients are isolated. So they then have to learn to do self sort of douching with saline. Well, you could add betadine. There is no harm. Betadine has antiviral, antifungal properties. I'm sure it can be used. There was one study from India, from Pune, if I remember right, where they talked about having a betadine wash both for the patient as well as the surgeon prior to doing an endoscopy as a safe way of going about doing endoscopy. That was an interesting study. I don't see why it can't be done post-operatively. Yes, there should be no harm to my mind.
Okay, there's another question from the audience. Somebody's asking that, will prophylactic alkaline douching in all COVID patients for immunocompromised prevent invasive fungal sinusitis?
Fungal infection. And that is why I spent some time over it. And the person who asked the question, I hope you were there during that section of the presentation, because that will then tell you how actually steroids cause this increased fungal infection, why they cause this upsurge in mucormycosis. Another point that I didn't tell you about is in steroid, when you have diabetic ketoacidosis, an acid medium actually causes greater release of iron. Iron is normally bound to protein in the blood. And when that happens, actually the fungal organisms, mucormycosis, in particular, mucor is very fond of iron. And so this then helps it to proliferate even more. So that is why diabetic ketoacidosis is more often associated with mucormycosis. So all of the immunological mechanisms in innate immunity are totally thrown out of gear when we give steroid therapy. And that is why you have this upsurge in mucormycosis.
I'd like to add a comment with your permission regarding this.
Sure.
So, as we know that COVID-19 is a viral infection, and viral infections do cause neutropenia.
Yes.
So neutropenia, and then you add steroids, that causes more neutropenia. This has a synergistic effect in the causation of invasive fungal sinusitis. So yes, it's, as you rightly mentioned, it is a major factor. So there's somebody who asked about if there's a patient who has undergone a liver transplant and he's suffering with COVID, post-COVID mucormycosis, which antifungal do you suggest?
So, well, the first step though is to assess the extent of the disease. All right, this is in all of these fungal infections, assessing the extent I feel is very important, because then you convey the prognosis to the relatives. Remember, the prognosis is not that great in the management. We got, even at the best, with surgery and treatment, around a maximum of 80%. So what about the 20%? So really you need to look at prognostic factors and advise the patient's relatives accordingly. But in the event your patient with liver transplant had very early fungal sinusitis, I would say, after doing an urgent smear and confirming it is mucormycosis and histological proof, go ahead and start on liposomal amphotericin B. By and large, liposomal amphotericin B doesn't have hepatotoxicity, and you could definitely give that. It is when they have renal toxicity, of course, you have a problem.
A lot is being talked about oxygen therapy and as a causative factor for mucormycosis. People are asking about cleaning the tubings, the mask, methylene blue and whatnot. Could you throw some light on this thing?
Really, I found that quite an interesting dialogue that's going on. I'm not too sure, because mucor is ubiquitous. It
Exactly.
is in a small particle. It is generated just the same way that COVID virus moves around. Perhaps even mucor can form, mucal spores can sort of get disseminated. So simply by adding some chemical which may not have much of antifungal effect, that remains to be seen. I am not sure. I have not heard of specifically of methylene blue being effective. Definitely betadine, we have some idea, but not of methylene blue. So I'm not too sure that helps the situation. When you use, you need humidification of oxygen, please ensure that patients use saline. Saline that you buy is sterile, and it should be all right if you simply use saline for the humidifier. But other than that, I don't think anything else makes a difference.
I think that sums it up. We don't want to hold you for long.
Sure.
Thank you very much. It's been a very informative talk, and I'm sure people who have been participating in this webinar have been benefited, as I have been benefited by your talk. Thank you once again. Thanks a lot, ma'am, and we hope to see you more often in these academic activities. Thank you very much.
Thank you so much, Dr. Imtiaz. It was so wonderful to have you as a moderator, and I hope whoever listened in had a good time too. Thank you again. Thank you to the organizers again. All right. Can I just stop here?
Yes,
I can leave.
Yes.
Okay, then.
The co-host, Mr. Hazim, can we conclude? Hatim, or is it? I'm sorry if I got the name wrong. Dr. Saud?
Yes, we can start leaving the meeting, and
thank you. Thank you for that.
If anybody has got further questions, they can send us an email.
Yes.
And we will forward it to Madam as per convenience. We'll get back.
Sure. Sure. Thank you so much, Saud. Thank you.
Thank you, everybody. Thank you.